Okay, so now we'll start with our mood disorders. So far we have done all the psychotic disorders, and now we'll see what are the major mood disorders, right? So accurate diagnosis of mood disorders require careful past medical and psychiatric history, because the psychotic disorders and the mood disorders are kind of like interrelevant to each other. So this is very important. Then the same thing, we have to rule out the substance, other medical conditions. Mood episodes represent a combination of symptoms. So predominant mood that is abnormal in quality or duration. So this is important to diagnose whether the patient is having like the major depressive episode, manic episode, mixed or hypomanic. So according to DSM-5 criteria, we will check how we can distinguish these things. So what are the main mood disorders? So the first one is depressive, can be major depressive disorder and persistent depressive disorder. So we'll see what is the main difference between these two. Now the second one is bipolar, bipolar 1, bipolar 2, and cyclothymia. Now the third one is induced by or due secondary to general medical conditions, substance, and all those. So basically the first two are important for the psychiatry. This one, depression and bipolar. So now the medical workup for mood disorders is the routine screening, physical exam, CBC, just to rule out like the other conditions, right? Maybe the patient's mood is affected because of any other medical condition, or maybe he's under substance abuse or something like that. And then additional screening in older people, vitamin B12, neurological consultation, chest x-ray, just to rule out everything before diagnosing the mood disorders, right? So what are the main criteria for the major depressive disorder? So this is basically the famous mnemonic, MSIG.
Maria, what's extended electrocytes?
Where, sorry?
In the medical workup of mood disorders, they have written extended
So
electrolytes.
I think in the extended electrolytes, they include everything like potassium,
Everything like
calcium.
calcium, magnesium,
Yeah,
serum electrolyte, sodium, potassium,
yeah,
chloride, bicarb, everything, I think.
yeah.
Okay. Okay.
So
Thanks.
yeah. So this is like the famous one, MSIG-E cap, to diagnose the major depressive disorder. So what is MSIG-E caps? The first one is mood. The patient's mood is depressed. The second is sleep, but the sleep can be increased or decreased, both. And then interest is decreased. G is for guilt. E is for energy is decreased. C if for concentration is decreased. Appetite. So the sleep and appetite can be increased or decreased, both, right? And then P is psychomotor, agitation, retardation. And then the last one is suicidal ideation. As we have done the suicidal thing, like it is very important to rule out the suicidal ideation in the depressive patients, right? So this anhedonia is, I think, a lack of interest or decreased interest, right? So what is the DSM criteria? The more than 5 symptoms should be present for at least 2 weeks period. So these are like, I think these are 9 symptoms. So from these, the at least 5 symptoms should be present. So and represent a change from previous function. At least one of the symptoms is either depressed mood or loss of interest. So the first two ones, like the depressed mood or loss of interest, should be present, and then all the other ones that we have studied, right? So depressed mood and then markedly diminished interest, significant weight loss or weight gain, both can be present. Insomnia or hypersomnia, both can be present, like one of, like either insomnia or hypersomnia. And then psychomotor agitation, retardation, fatigue, and then feeling of worthlessness, and recurrent thought of death, fear of dying, suicidal ideation. So all these symptoms could be present. So any 5 of these. So usually in the question stem, they are writing like different. So we actually have to count the symptoms. Like, okay, now the 5 symptoms are present, so the diagnosis can be made. It's like pretty hard, but then we have to remember this. And then the symptoms, clinically significant distress or impairment in social, occupational, or other important areas of functioning. So that is important, like the patient's daily functioning is affected because of these symptoms. And then the episode is not attributed to direct physiological effect of substance or like other medical condition, right? So this is like the line is almost written everywhere. So Now, this is the major depressive disorder, and now the second one is manic episode, right? So the this is kind of opposite to the this one. So the main mnemonic is like they have written here GST paid, so you can remember this. But dig fast is also one of the famous one. I think in U World and everywhere else they write it dig fast, so whatever easier for you. So basically it is grandiosity, and then sleep is decreased need. So there the sleep can be increased or decreased, but here the patient having decreased need of sleep. Like even if he's sleeping for 3 hours, he have when he wake up he has like so much energy and like he is so much hyper kind of. So this is important to remember for the mania. And from all these, at least three or more should be present. And the patient is very talkative, pleasurable activities increased, idea, flight of ideas that we have studied before, distractible. So basically, these are the things. I think I have one mnemonic for the. Uh, no, I think I don't have. Anyways, so this is the distinct period of abnormality and persistent elevated irritable mood and abnormal persistently increased goal, direct activity or energy, and this is lasting more than 1 week and present most of the day, nearly every day or any duration if hospitalization is necessary. So basically, so I think someone has like mentioned like this is 2 weeks, so this was like 2 blue weeks, something to remember like this, and this is 1 fun week. So 1 fun week and 2 blue weeks, something to remember. Someone said that. So, anyways, so the second criteria is during the period of mood disturbance and increased energy or activity, more than three of the following have persisted. Four if the mood is only irritable. So, if there is only mood is irritable, then four the symptoms should be present. Otherwise, more than three of the following symptoms and also present to a significant degree and represent a noticeable change from usual behavior. So these are all the symptoms that we have just studied here. Self-esteem, grandiosity, decreased need of sleep, more talkativeness, flight of ideas, and all these. And then the mood disturbance is sufficiently severe to cause marked impairment in social or occupational functioning. So this is important. This criteria should be met. The functioning should be impaired, and then it is not attributable to any psychosocial effects of substance, other medical conditions. So this should be ruled out. And full manic episode that emerges during antidepressant treatment but persists at a fully syndromal level beyond the physiological effect of their treatment is sufficient evidence for a manic episode and therefore a bipolar 1 diagnosis. So we will see what is bipolar 1, but yeah, if there is like completely one manic episode, so they can diagnose it as bipolar 1. And then criteria A to D constitute a manic episode. At least one lifetime manic episode is required for the diagnosis of bipolar 1 disorder. So because in bipolar 1 the main criteria is the manic episode, so that's why they are saying the at least one at least one lifetime panic episode. Sorry, manic episode. So now the next, this was the manic episode criteria for mania. And now, what is hypomanic episode? So, criteria A and B of manic episode is met, but the duration is more than 4 days. So, here the duration was 1 week, and in the hypomanic, the duration is four or more days. So, what are the A and B criteria? The A was this, like irritable mood and all this, and the second was this one, more than three of the following present. So I think the A and B criteria is same. It's only here it was one more than 1 week, and in the hypomanic it was 4 days. So episode associated with unequal change in functioning that is uncharacteristic of individual when not symptomatic and observed by others. So episode is not severe enough to cause marked impairment. So that is the difference between mania and hypomania. That this is causing functional impairment and also it is causing the um, like it was severe enough to cause functional impairment and 1 week, but here it is not causing marked impairment in functioning, and it is for 4 days. And absence of psychotic features. If they are present, the episode by definition is mania. So the main difference, like two or three differences, is duration and then the functional impairment. And the third one is psychotic features. Psychotic features are present here, but in the hypomanic episode, it is not present. And then the third one can be the mixed features. So it can be manic, hypomanic, and bipolar DDI 1 and 2, and then indicate presence of both depressive and manic episodes. So it can be like mixed. So that is basically it. So this one is the major depressive disorder. So presence of single MDE, that is the major depressive episode, versus recurrent, which require presence of two or more um, major depressive episode to be considered as separate episode. There must be interval of at least two consecutive months in which criteria are met for MDE. So basically, this is major depressive disorder. So what is difference between major depressive disorder and major depressive episode? In the episode, there is only single event is present, right? But in the major depressive disorder, there must be interval of at least two consecutive months, and it should be two or more MDEs should be present to diagnose as disorder. And then the MDE is not better accounted for by schizoaffective disorder and is not superimposed on schizo. So all these needs to be ruled out. And then there has never been a manic episode or hypomanic episode. For the MDD diagnosis, there shouldn't be any manic or hypomanic, otherwise it will be bipolar and like those kind of, right? So this exclusion does not apply if all of manic like or hypomanic like episodes are substance or treatment. So obviously these medical conditions and substance abuse or like substance effect should be ruled out before diagnosis can be made. And anxious distress, mixed features, and different kind of features like mixed catatonia and all these can be present. So this is the major depressive disorder. And then the Canadian lifetime prevalence is, so which is also in young people 15 to 25, more common in females. And then this is the biological etiology, like it can be present in twins and first degree relatives. So family history is important as we have studied before. And this is all the pathophysiology was happening. And then psychosocial, cognitive, environmental factors, and all these factors can be present. And then what are the risk factors? It is sex, female to male 2 to 1. Then family history is important, alcohol use, depression, suicide attempt, childhood experience. So all these stressors, low socioeconomic status, so all these risk factors for the depression. Now this one, clinically significant depressive symptoms in elderly. So affects 15% of community resident more than 65 years, up to 50% in nursing homes. So that is like a huge number. So that's why it is very important to rule out the depression in elderly, because in nursing home more than 50% are like depressed. So high suicidal risk due to social isolation, chronic medical condition, and all these. Male age 80 to 90, suicidal peak, and female is 50 to 65 years. Low mood or dysphoria may be a reliable indicator of depression more than 70 years, and often present with somatic complaints, change in weight, sleep. So all these can be present and may have prominent cognitive changes after onset of mood symptoms, dementia syndrome of depression. So in the elderly, like with the depression, all the other stuff can be present. So this is important to rule out. And then what is the treatment? The first thing is lifestyle, like aerobic exercise, mindfulness techniques, sleep hygiene, and all those stuff. And then what are the biological therapy? SSRI, SNRI, antidepressants, somatic therapy. So non-pharmacological first, then pharmacological. And for MDE of moderate or greater severity, first line pharmacotherapy are used. And most second generation antidepressants with escitalopram, mirtazapine, sertraline, and venlafaxine. Citalopram showing evidence of superiority. So these are the first line therapy. And then non and partial response, optimize the dose, switch to antidepressants with superiority, or add augment. So I think there is a chart, we will review that, like how we will add the therapy and like how we will change the therapy. And typical response to antidepressant treatment, physical symptoms improve 2 weeks. And then mood cognition by 4 weeks. If no improvement after 4 weeks at the highest tolerated therapeutic dose, alter the regime. So this is basically the criteria. So if the patient is coming like after just starting the antidepressants and she's saying I'm not having any improvement, so this is important because the improvement happens after 2 weeks. And then mood and cognition by 4 weeks. And if there is no response after 4 weeks, then switch to other regime. And then ECT is the currently fastest and most effective treatment for MDD. Consider in severe psychotic, like all the treatment failure. So this is treatment resistant cases. Then the last thing is ECT. And RTMS, first line treatment for MDD for patients who have failed at least one antidepressant treatment. And this is also the other um, therapy, equivalent to medication but not to ECT. Phototherapy is the other one. So these are all, but ECT is the most effective one. And then the psychological, the CBT and all those therapies, social, experimental, these all. So the prognosis after 1 year without treatment, 40% will still have symptoms, and then 20% will continue to have symptoms. So this is just the prognosis. So the next one is the persistent depressive episode. So this is also called dysthymic disorder. And what is the definition? That the depressed mood for most of the day, for most or more days than not, as indicated either by subjective account or observation by others, but it is more than 2 years. So the main criteria is the depressed mood is present, but it is present for more than 2 years. In children and adolescents, moods can be irritable and duration must be at least 1 year. So in the children, it is not always like these depressed mood is not always seen, but it is kind of opposite. It can be like irritable and they are like very like not behaving properly and those kind of like different symptoms, and the duration is more than 1 year. And the second criteria, presence while depressed more than two of the following: poor appetite and insomnia, hypersomnia, low energy. So all these symptoms that were present in the major depressive episode, but in this thymic, we need two or more of the following and 2 years. So two is the main number in the dysthymic. And then during the 2 year period and 1 year for the children, the disturbance, the person has never been without the symptoms in criteria A and B or more than 2 months at a time. So it should be more than 2 years, but not more than 2 years, sorry, not more than 2 months without the criteria A or B. So these symptoms should be present kind of continuously. And then criteria of major depressive may be continually present for 2 years. There never be a manic episode, hypomanic, and never met a cyclothymic disorder. So all the other, we have to rule out all the other one, because if it's manic and hypomanic, then it is bipolar. And disturbance is not better explained by persistent schizoaffective. So like all the other psychotic disorders have to be ruled out, and then the substance disorders and everything. So these are just the specifiers can be like present with all the other conditions. And early onset is less than 21 years, and late onset, so that like any in any age it can be present. And with pure dysthymic syndrome, full criteria have not been met. So these are just the specifiers. And then lifetime, male and female equal. And treatment is this like the psychological and then biological. So the first one is the psychotherapy, and the second one is antidepressants, SSRI, sertraline, and TCAs. So basically, all these are present in the uh, persistent depressive disorder.